Aloha, welcome back to Healthcare in Hawaii. My name is Josh Green, State Senator and Emergency Room Physician on the Big Island, trained as a family physician. Today I'm really excited to have a guest that is another fellow physician, although much more qualified than myself. Kelly Withy, physician, she's an MD, PhD, went to Harvard, and then on to medical school at UC San Diego. Has a vast wealth of information and knowledge on the area of healthcare and physician shortages. She's been our expert here in the state of Hawaii for several years and is the director of several programs. She's first the director of the Area Health Education Center. She's that program director, and we're going to have her describe what that program does and how it's helping us to deal with the physician shortage here on our islands. She's also the State Loan Repayment Program Director, which helps us get federal monies and even some state and contributions from philanthropic organizations, get some monies to people to repay their loans if they're going to practice as physicians or healthcare providers in our state. She also works on the physician workforce assessment, which again she's the director of, and that's been very helpful for us to pinpoint where our shortages of professionals, especially docs, are across our state. So I want to introduce you to Dr. Kelly Withy.
Thanks for having me, Josh.
It's a great pleasure to have you here today. Why don't you tell us a little bit more about yourself, Kelly? What kind of makes you tick? What are you interested in as far as these issues? You seem to be the go-to person for our state.
Well, my personal goal is to make sure that everybody has the health care they need here. And I work on the people end of that. So making sure there are enough providers, whether it's doctors, nurse practitioners, physician assistants, med tech folks, everybody that makes up the team that takes care of people. So one of my goals I consider is to make sure we have plenty of happy doctors in Hawaii. And I can't say we really do right now.
Mm-hmm.
So part of my job is to help improve that.
It's critical because I think what you laid out, first of all, you said so many important things that I'd like to unpack right off the bat. You mentioned not just the docs, but nurse practitioners, there's psychologists out there, there's social workers, straight up nurses, and we've had these conversations constantly about patient-centered medical home, accountable care organizations, all these new kind of newfangled programs that I've had a lot of guests come and talk about, but you're really one of the people behind getting all these professionals into the discipline here in the state of Hawaii. When you say that it's challenging to make docs happy, what are you seeing? What are you hearing from them?
Well, we have lower pay than many places on the mainland, but that's not the only thing that makes people want to be healthcare workers. But it is an important one here where our cost of living is very high. Right. We also have some specific challenges to our medical neighborhood. We may be very isolated, and in some of the rural communities, if you're the only provider, you're on call 24/7, and it's very difficult to do. So we have some groups that are basically like a house of cards. If there's 3 doctors in a group and one leaves, the other 2 just feel they can't make it. So there's lots of issues there, of course, with rural areas. And in those rural areas, you don't have the medical community you may want. You don't have specialists to refer to easily. Until we perfect a telemedicine system, it will be very hard to get your patients the services they need. And that's hard on doctors, not to be able to get what they need for patients.
Believe me, I definitely want to make sure we get to telemedicine because I haven't had someone with your expertise talk about that yet to us, and that's something I'm very interested in. I can tell you a story. One night I was on call in the ER, and I had my second bout of kidney stones, okay? And I was the on-call doctor in the countryside, and it was the weekend, so that was it. So I had to have the nurse put an IV in me, and I'm getting IV fluids, and I can't take any pain medicine, of course, because I'm on call, but I could keep an IV and get fluids throughout the night because there was no urologist for me to see. I didn't have a CT scanner, and I was the guy taking care of people. So,
and you were probably worse off than they were.
It was terrible. I mean, I'm taking a lot of Tylenol, but that doesn't do it sometimes when you get a kidney stone. Yeah. So the shortages can be profound, and I'm not sure people realize how short we sometimes can be. Why don't we take a step back? I've seen you speak quite eloquently on many occasions about what our overall healthcare shortage is. Could you give us a little bit of an idea?
Well, there's no perfect measure of demand, but if we compare our population here to a similar sized population on the mainland, we have 700 physicians less than that population does. So we have 700 less on average than on the mainland for our size. So you could say we're 700 short. Now, we don't have 700 jobs for doctors.
Okay.
So that's a compounding factor. We need them, but we can't necessarily pay them.
Gotcha. Does that mean that the Queens of the world and HPH and others just aren't hiring, or is it too difficult to set up your own practice? What's the situation?
Both, all of the above.
Okay.
Doctors these days that are coming out of training, they don't want to set up their own practice. They don't even know what it means to hang a shingle.
Right.
Because they haven't thought that way. They want a job, they want reasonable hours, they want reasonable pay, which is all quite reasonable.
Sure.
But the old style was you went out on your own in practice into a rural community, and they've shown that having a doctor set up practice in a rural community brings in $1 million to that community.
Interesting.
But we don't have that model anymore. And in fact, the solo rural provider, I think, is a byproduct, or is going to be eliminated somewhat by the ACA because of the emphasis on being in a team with a hospital and resources that in rural places you just might not have.
That's an interesting thing. So a possible casualty of the Affordable Care Act will be the further demise of the independent physician model.
That's my fear. Hopefully they'll watch for that and support that, but right now you don't get any more money for practicing out in the middle of nowhere, and yet you have less patients, so you have less income.
Right, and it's very difficult. If you like, I worked in a place like Ka'u on Big Island when I first came here, and the only way I could have possibly done that was because it was a part of a community health center. There's no way on earth I could have just set up shop. And even the doctors I do know that set up in Ocean View, nearby, that practice was never able to sustain itself economically. So you said 700 short. That represents what, 15-20% short? Is that the number?
That's about right.
Okay, and are we seeing that across the country and other places?
Some places, some states train more than they need,
Okay.
so they actually have a surplus. But unfortunately, many providers are going into specialty care instead of primary care, and that's where our greatest shortage is, in primary care.
Unpack that for me a little bit. So what's your definition of primary care? I've had other people give definitions.
Well, family medicine, internal medicine, pediatrics, geriatrics, and general practice. For our loan repayment, we include psychiatry and OBGYN in that definition as well.
Okay.
But I would say anybody who's taking care of a majority of people's healthcare needs.
Okay, and so those are the primary care people, and are we short more than 20%?
About half of our shortage, so about 350 of the providers are in primary care.
Okay.
Half of the shortage is primary care.
Now, in the community, I hear a lot of times people say that they are on Medicare and they're on Medicaid and they're having a problem. Is that a bigger problem than for people who have private insurance? What's your experience?
It probably is, yes. Of the psychiatrists that we surveyed, only a third take Medicare and Medicaid.
Okay.
So that's the only specialty we've actually gone into that much detail. The physicians have just finished filling out a survey with their licensure, and hopefully they answered those questions, but we won't know until we get that data.
Yeah, I think that's awfully important because I'd remind our viewers that one of the parts of the solution for the country has been to decide, controversial or no, to try to provide insurance for everyone. And in the state of Hawaii, we're going from 295,000 individuals on Medicaid to about 360,000, I'm told. So another 65,000 people on Medicaid where the reimbursements are
Much less.
much less, right. So, and I know that Big Island's already about 50% Medicaid. So when I talk to my friends on Big Island who are practicing, they're not complaining to me about money. They're saying simply that they don't have enough hours to just all day long to see patients and still pay their bills for their staff. And I'm wondering if it's going to get even worse if we see that Medicaid expansion and we don't have some other way to help. Have there been any solutions that you've come across on this? What are we going to do you think, if we have a surge of Medicaid and we're at the same time making a pitch to have people go into primary care?
Well, if we restructured the payment system such that it wasn't so volume dependent, and we made it more team-centric and beneficial to patients, I think that would go a long way. A lot of the Medicaid population has more health challenges or socioeconomic challenges than other folks, and so they could be considered a high-risk group. So wouldn't it make sense if somebody's more complex to perhaps pay people a little more to take that extra time with them? And so if we have a new payment methodology that rewards caring for a group of people, complete care, down to prevention and community outreach, and working in a team, I think that would make it much better for providers and patients.
I'm really glad to hear you say that, because there are some opportunities. A couple things come to mind. One is that there are some grants right now and programs that Department of Human Services is looking at. They're getting basically a 9-to-1 match, I believe. So the state's talking about putting $2 million up and bringing $18 million additional dollars in to work on people with comorbidities. For our viewers, that's 2 or more health problems. Probably mental health issues and diabetes is a possible pair, and those extra resources could go to these teams. I suppose you're describing a doc that's working somewhere in Hana or Big Island or Waianae, away from the center where they have real active practices, and that might bring some extra dollars. Another thing that I did notice was that the Medicaid program itself, we spend about $2 billion a year on now for this population of, well, now it's over, well over 300,000 people, but of that, 60% of that was spent on just 4% of the population. So 4% of 300,000 individuals was 12,000 people, but it was well over $1 billion. And I think that the conversation has now gravitated towards things that you're talking about, which is maybe we can provide this care better. Is that how you would begin to approach it?
Yes, definitely. And the Governor's Health Transformation Task Force is talking about care coordination networks and really helping these people out with their challenges.
Right.
It's very important. And I would even go a step further, and I would say, well, what if we, instead of having, because another thing that frustrates doctors is all the paperwork.
Right.
They have 15 minutes to see people, and of that, maybe they get 8 with a patient.
Right.
But the reason we went into medical school is to work with people,
right.
not computers,
right.
not paper, not books, So if there were some way we could have a base pay, like a per member per month, of a reasonable amount, like $25,
right.
for taking care of a group of patients, so that you don't have to worry about having them come in every week for their blood pressure check, because that's the only way you can bill, or and you could text visit with them.
Sure.
You could feel you had reimbursement for your phone calls and you were appreciated, and you could manage their care, not just their office-based care.
Right.
I think it would go a long way. There's actually a model on the mainland for primary care doctors where they're just starting to ignore insurance and charge their patients $25 a month for their services and do everything outpatient they can for them, and they seem to be much happier. There's no quality metrics reporting, there's no billing, there's no prior auth forms, there's no formulary issues. They can just spend more time with the patients, and the patients seem to love it too, because they get a half hour.
Sure.
Yeah.
A lot more time. Yeah, that's going to be fascinating to see how that develops, because I think that we're in an era of extreme change, right?
Mm-hmm.
And it's funny you mentioned that, because I actually asked HMSA if they would consider a program very similar to that, because we're seeing some reluctance in certain parts of the state to take care of everyone that's got either Medicaid or Medicare, that we probably are going to have to be a little bit more creative to actually provide services. And providing that kind of reassurance to the docs, I think, might go a very long way.
I think they'd love it. They would also love not to be travel agents for their patients.
Yeah.
Because apparently, if you're on a neighbor island and you need a consult for one of your patients, you have to start a prior authorization form, which
Right.
is a lot of work. If for some reason that visit is canceled, you have to restart the prior authorization form, do it all over again, and they may find out the day before that they get to travel or they don't get to travel. And I've had doctors say, well, we're not travel agents.
Yes.
Why are we doing this? So it's very frustrating, all the paperwork and hoops. If we could take away that burden, that would go a long way to provider satisfaction.
And which would in turn keep doctors practicing.
Yes.
Okay, well, I think this is a good place to take our first break. When we come back, we're going to begin talking about one of the programs you've championed, which is loan repayment, talk about how that works nationally and locally. Great. So I'm Josh Green, your host for Healthcare in Hawaii. Thanks for joining us. I'm joined by Dr. Kelly Withy today.
Castle and Cook, Hawaii. Investing in Hawaii, creating communities, and providing for the needs of our state. Collateral Analytics. empowering the real estate industry to make better informed property investment decisions. The Foreign Trade Zone, bringing the benefits of the Foreign Trade Zone programs to Hawaii businesses and entrepreneurs. Galen Ho, a senior executive of BAE Systems, a global defense, security, and aerospace company. Hawaiian Electric Company and its affiliates Maui Electric and Hawaii Electric Light Company on Hawaii Island. The Hawaii Energy Policy Forum, incorporating diverse perspectives to design a flexible and forward-looking energy strategy. Hawaii Energy, the state's energy and efficiency program created to help Hawaii's residents and businesses adopt a clean energy lifestyle. Hawaii Gas, helping Hawaii achieve its transition to clean energy and a better energy future. Hawaii Pacific Health, bringing technology and teamwork together to transform healthcare in Hawaii. The High Tech Development Corporation, attached to DBED, is the state's leading technology agency. The Scheidler Family Foundation, supporting educational, cultural, and charitable organizations, including think tank.
Aloha, welcome back to Healthcare in Hawaii. I'm your host, Dr. Josh Green, ER Doc on the Big Island and State Senator. Today I'm working with Dr. Kelly Withy, who's an MD and a PhD, and who's been a leader in healthcare transformation, who's been a leader in healthcare workforce issues, and she's really spearheaded several projects which I really find both fascinating and important to the state of Hawaii. One of them is the State Loan Repayment Program. Kelly's been an advocate for this program for some time, and I'm going to turn it over to her and have her first give us an overview of the program.
Well, I've wanted a state loan repayment program in Hawaii for a long time. And in order to get federal money, you have to have local money to match. And it took me years to realize it doesn't have to be legislative money because we haven't been successful with that yet, although hopefully that will change. So I actually went to medical groups here, insurers, and HMSA in Queens stepped right up and said, yes, this is a good idea. We want to do this. Aloha Care came along too. And they gave us money that we then got dollar for dollar federal match. Not as good as your, 18 to 1, but dollar for dollar was good enough for us. So 2 years ago we started this program. You get up to $40,000 paid directly to Sallie Mae or whoever the bank is that holds your loans every year. And it's a 2-year commitment to a health profession shortage area, which in our case is mostly our community health centers, our Native Hawaiian healthcare system, our prison system. Or a nonprofit organization in a census tract that is a health profession shortage area.
Why don't you tell us a little bit more about these HPSAs, right, health profession shortage areas. Historically, they were used for the federal loan repayment program, is that right? Mm-hmm. But this is a different program. Mm-hmm. Could you unpack that for those who might be watching or who are maybe a doctor coming out of residency and is looking for a place to go?
Mm-hmm. Well, first of all, they don't have to be a doctor. You can be a nurse practitioner, a physician assistant, or an MD or a DO.
Great.
And we're hoping that we're going to expand it to social work and psychology this year if we get some legislative funding.
Great.
But it's actually administered by the same office as the National Health Service Corps loan repayment.
Okay.
But the difference is that while you have to have a HPSA score, that score can be 0. We do not prioritize by score, because it's a state-run program.
Oh, interesting.
So they give us more leeway. So we have places that weren't able to get National Health Service Corps money, but we can step in and give them state loan repayment money. So I think that's one of the big advantages of this program. So the two can complement each other.
Sure.
Because there's about 50 National Health Service Corps scholars right now in all different health professions.
Right.
And right now we have 16 in our second year loan repairs from all islands except Kauai.
Interesting.
And we really wanted the Kauai one, but we couldn't make it work.
Well, this year, for sure.
Hopefully, yes.
So, okay, just to give people perspective, when I went to the National Health Corps, which was 2000, I had a scholarship, so I had to go to a HPSA that had a score, I think, of 15 or greater. This is 0 to 30, I believe.
28.
28, okay. And so I went to a very rural place at Ka'u, and I was kind of the only guy around there, which actually was a wonderful experience for anyone who's watching. I really mean it, because you immediately get integrated into the community, and though it could be challenging to spouses, I could imagine, or others. I didn't have a spouse. I had a dog and a Jeep, so it was great for me. But you're saying, though, that now this will expand us statewide. And I should say, I guess, so right now, at least, and we'll keep our fingers crossed and knock on wood both, we've asked for $1 million from the state. And if monies come in, then you're able to get matching monies. Is that right? How does that work?
We apply to the federal government, the Health Resources and Services Administration. Like I said, same branch as National Health Service Corps, for a state loan repayment grant, and they match it dollar for dollar, what we're able to provide. None of that can go to administration, so we do that internally at the med school, who's very supportive of this. But we have that money for the length of the grant.
Got it. Who do you prioritize? What kind of docs or nurses, or how do you decide what the best people to go into the program are?
Well, luckily this year we were able to fund everybody that met the criteria. But what we're looking for is dedication to that community in particular, so experiences there, whether you grew up there, did a rotation there, work there already, dedication in general to the underserved, the match with the site, and then your basic experience with underserved, with patient-centered medical homes, electronic health records, willingness to teach and do outreach.
Okay.
So we have a wonderful group of loan repayers that are very dedicated to the people where they're serving, and it's really heartwarming to work with these folks.
Why don't you tell me a little bit? Don't tell me the names, but tell me a little bit about some of the people that are doing loan repayment, because I think just to kind of reshape this discussion, we're talking about pretty severe shortage statewide, as you described, 700 providers or docs, and then difficulties as well getting people to take care of patients that have Medicare or Medicaid. But your team, your core, so to speak, of people take care of everybody. Is that right? Okay, so what are these people like?
Well, they're diverse, just like our state, but probably about half of them are from Hawaii, half of them are from elsewhere. A little less than half are physicians, and 9 are nurse practitioners. So it's pretty balanced there. We don't have a physician assistant yet, but we would love to have one. They are in many rural areas, and they're doing activities there. Most of them are family, internal medicine, or pediatrics, although we have a psychiatrist in the prison system. We have an OBGYN on Maui.
Yes.
And they're all doing community activities such as substance abuse prevention activities or domestic violence prevention activities. Many of them teach our medical and nursing students. And many of them are from the areas, grew up in the areas where they're working, and hope to stay there forever, and I hope they stay there forever too.
Right. You once told me that people that we train locally or get into these communities through programs like this stay more often than not, and the numbers are much better. What are the statistics on that?
As far as training locally and keeping them, well, actually, we're the best state in the country for keeping our own.
Great.
So if somebody goes to medical school and residency here, the chances of keeping them in Hawaii are 90%.
Wow.
So we're #1 in the whole country.
Excellent.
But, we only train 76 medical students and 90 residents a year. So even if we kept every single one of them, we probably wouldn't have enough until we got an influx of more, or we figured out a way to make our teams really effective and could care for more patients with one provider.
You said something important to me in the break that I wanted to mention, and that's that we have kind of an aging physician population right now in the state. Could you unpack that a little bit? Because I'm interested in whether we could even if we can maintain, let alone catch up to this 700 physician shortage that you've expressed and told me about. So what's the scoop with our aging physicians?
Well, I'm just getting new data in, so this is a little bit outdated, but our average physician age is 54,
okay.
Which is older than the mainland.
Yes.
And what did I tell you, 15% were over? No, 20%?
24%, I think you told me.
Are over, are nearing retirement age. And these are a lot of the solo or small group rural providers who can't recruit someone to work with them. So we have an added challenge in that.
And so this is the kind of place, I suppose, where they need some other carrot to lure a young doctor or a young nurse practitioner in, and just maybe being able to say, hey, we can give you 2 years of loan repayment so that you don't have to worry about your debt if you'd be willing to transition to a rural practice or a practice with
Right.
an older mentor. Yeah, that's very interesting to me. And I know that we also hear periodically from people that the Affordable Care Act has them down, as providers, and they're concerned or they're frustrated by what new mandates may come out, and maybe they're just going to give up and not practice any longer. And that really worries me. So I think what you're doing is, by spearheading programs like the loan repayment program and, advocating for its expansion, we're going to need something. Now, what's the prospect of growing the medical school size, growing the residency size, snatching a bunch of doctors from Texas or California? Tell me a little bit about those possibilities.
Well, those are three different, distinct possibilities, all good.
Yes?
The medical school, I think, would be happy to expand class size.
Yes.
In fact, I believe the goal, right now we're at 66, and I believe the goal is 75, but we need more resources.
Sure.
We depend on volunteer teaching for much of it,
Yeah.
and so we need more ability to do that, but we also need money for our students to go to neighbor islands, because we have plenty of folks
Sure.
there who want to teach, but it's expensive to transport folks back and forth and house them. So I think the medical school would love to, I know the medical school would love to expand if possible. And A.T. Stills University at Waianae, likewise, they've increased our capacity. However, we have a bottleneck at graduate medical education. Luckily, we have a new program in Hilo for 4 residents a year, which is thrilling, and it's an interprofessional program, and it's in a rural area. I love it.
Yeah.
But they're not getting any graduate medical education money. As you know, they're coming to the legislature for money every year because medical education is expensive.
Right.
Because the federal government hasn't opened up graduate medical education spots. And right now we have exactly the same number of medical school graduates that come out of U.S. graduates that come out of training as we do the number of first-year openings, interns. So we have another number in that pile, of course. We have international medical graduates, which do a lot of great work for us.
Right.
But that puts us over the top so that we have U.S. doctors every year who don't get into postgraduate training because there aren't enough slots.
So you're saying that we should, when you say postgraduate training, residency training, right?
Yes.
So if you were, the almighty head of these departments, you would expand residency programs?
I would expand primary care residency programs.
Interesting. And that is what we're doing. I think they received a $2.8 million appropriation, but it's going to be necessary to make sure that that program has a good foundation and then even grow it further. And what you're saying is then if we can arrange housing and so on, bring some of the medical students as we expand the class to Hilo, to Kona,
Definitely.
to
And they're
Maui.
already there, but it's expensive.
Right.
We want more there.
Now tell me this, you once told me that by getting these medical students, young docs, into other communities, we sometimes can retain them. Is that how it goes?
Well, if you don't know what something's like, you probably won't even consider going there.
Right.
But just having them do a rotation in a place like Ka'u, where you were,
Yes.
and seeing how wonderful the people are and how they embrace the healthcare provider and can really make a difference and can change the way people think. Because if you only train in a hospital, you'll end up in a hospital working.
Sure. Tell me this, what's our potential for partnering with some of these other institutions like the community health centers to add training? There's doctors there, there's nurse
Yes.
practitioners there.
Yes.
What's the barrier, if any, to setting up or expanding some of our training programs to have them volunteer? Do we need money?
We do need money.
Okay.
I mentioned it's very expensive to do medical training. It's very labor intensive.
Okay.
And right now the impetus is on volume of patients seen. So if we go back to that healthcare reform idea of changing the way
Yes.
people are paid to care for the whole patient, then the medical student and the nursing student and the PA student could be team members, and they could help manage care and help make everybody healthier and not be a drain on the providers. So right now you're required to see 20, 30 patients a day.
Right.
If you have a medical student with you, that probably will decrease by 5, or you'll be there an hour later
Right.
at night, which some people do. But right now there's no adequate compensation for that type of activity unless you have an agreement like with A.T. Stills. So it's very hard for people to teach. It's got to be a labor of love.
Gotcha. Or some resources through a new model, and
Right.
and that's something I think that Could very well happen because the current model is shaky at best for a lot of providers, and I think as these new models start emerging, like the CIPN, we're hearing a lot about that. That's the Clinically Integrated Physician Network. There's some added resources that they're putting there. Maybe we shouldn't forget this need to have resources to place where doctors are going to be training. Okay.
I agree.
Well, this is a good place for us to take our second break, and then when we come back, we're going to delve into some, I think, of the specific shortages, the most challenging shortages that we've got in our state, what concerns you might have, and we'll kind of see where the conversation takes us. Okay, fantastic. I'm Josh Green, host of Healthcare in Hawaii, here with Dr. Kelly Withy. Thanks for joining us.
I'm Hong Jiang, host for Asia in Review on Tuesdays.
And I'm David Day, host for Asian Review on Thursdays. Both of us broadcast our respective shows at 4 p.m.
And my topics tend to deal with questions related to environment, culture, history, and sometimes human rights.
And my shows tend to be on international business, foreign policy, geopolitics, and national security. And you can watch our shows live on the ThinkTech website at thinktechhawaii.com.
And you can also watch us on YouTube or Olalo.
So come join us on Thursdays at 4 p.m. I'm David Day.
And on Tuesdays at 4 p.m., I'm Hong Jiang.
Aloha.
Aloha.
Aloha, welcome back to Healthcare in Hawaii. I'm your host, Josh Green, chair of the Health Committee here at our Senate and a weekend warrior in the ER. I'm joined by Dr. Kelly Withy, who's MD, PhD, works with JABSM, runs several programs, has had a major clinical presence here for years, and is really working on our healthcare physician shortage and our healthcare provider shortage statewide. Kelly's been good enough to bring several hats with her today. She is the Area Health Education Center Program Director, the State Loan Repayment Program Director, which we spoke about in our last segment, and also does the Physician Workforce Assessment as its director. Now, that last job, which has been done extraordinarily well, has been able to describe some of the specific shortages. Is that right, Kelly? Why don't you, for those who don't know, many people live on Oahu and they don't necessarily sense the shortage the same way that other places do in the state. Could you tell us what our most critical shortages are as far as physicians?
Well, primary care.
Okay.
Even in downtown Honolulu, there are pediatricians who can't find an adult doctor when their kids are over 18.
Okay.
So we're starting to feel that now as well. Recently in Honolulu, we felt neurology shortages, gastroenterology shortages, but our number one shortage for specialty care is neurosurgery. And actually, while the numbers are much bigger in primary care, one can make a huge difference in many of these smaller, more specialized areas.
Sure.
On neighbor islands, each one is a little different, but neurology, urology, surgery, orthopedic surgery, especially on Big Island,
Yes.
as you probably know, are very challenging.
For sure.
And even endocrinology, rheumatology are ones that are big in different areas.
Specifically in more of the rural areas, is that right? Okay, so this is a cautionary tale I've told a lot of people, and that's, for instance, there is no neurosurgeon on the Big Island because the population is spread out, and you only have one neurosurgeon normally for a few 100,000 people. Okay.
Yeah.
So a state like ours is going to have challenges that are both reasonable because of population, but also geographic. You would, I guess, in a perfect world, want at least one, one certain specialist of each flavor in each of the islands. But I suppose that's just plain impossible when you talk about Lanai or Molokai.
Right, there's just not the volume to support them.
Right. And this neurosurgery problem, of course, is worrisome because of car accidents and strokes, both of which are somewhat prevalent here in the state. How many neurosurgeons do we have?
I believe we have about 8.
Okay.
But don't quote me because we're just getting our new numbers in, so
Yes.
then I'll know.
Right. And what does that mean? I suppose people would like to know, does that mean if there's a terrible bus accident, God forbid, or a plane crash, that we're not going to have enough physicians and specialists to take care of the individuals?
Well, we better hope that none of them are on vacation and off island at the time.
Yes.
But basically, we could use about twice that many, and then, of course, in any disaster scenario, we would need more.
Right.
But basically, they would all have to step up and come in and work extra. And then other people who may not have their particular skills, but general surgeons and other kinds of surgeons would have to step up too. And we'd need a good triage system.
Sure.
we'd need to work as a team.
Right. Let me ask you this. Let me just kind of put a statement out there and get your idea and your input on it. In my experience, I think that a lot of physicians and other providers have to kind of work in some ways beyond the scope of their traditional discipline. For instance, I've known a lot of internal medicine docs that trained in bread and butter medicine ended up gradually becoming endocrinologists or just self-described neurologists because they had some acumen in those areas, maybe some extra training, but there was such a shortage on one of the neighbor islands that though they would have liked to have practiced traditional primary care medicine, they end up getting pegged as a person who will do endocrinology or a person who will take care of HIV/AIDS. Is that happening?
I believe so, yes. And well, to hear it told, there's a lot of behavioral health issues that primary care may not even feel competent having to take care of, but has no choice because they have nowhere to refer to.
Right.
There's some people who are good at dermatology and some people who do more procedures, probably because of the need, but maybe it's also an interest, so maybe it's a good match
Sure.
for them.
Yeah, I can say this. If you like to be a cowboy, working out in the neighbor islands, you get to do it because one guy during an earthquake came into my ER and he cut his thumb off. And I mean, it was just kind of hanging on by a shred, and the road was down and the scanners were down. So I had the opportunity to reattach this guy's thumb while talking to a terrific orthopedist over at Tripler because that was it, and I saw him years later, and thank goodness it worked out. It wasn't beautiful, but it worked, right? And I do know a lot of doctors, both who like to do and take on added responsibilities, but on the other hand, I've also known a few docs come and go because they just felt like they didn't have enough backup. Is that one of the main reasons that physicians depart in the state of Hawaii?
No, actually it's not.
Why is it?
Well, of the physicians who come here to practice, my guess, and this is not an official guess, but about half of them leave within a couple years.
Okay.
And there's a myriad of reasons, but usually it's the family factors. We know pay is low, we know there's remote areas without as many medical specialists as you would like possibly.
Right.
But sometimes the spouse can't get a job. Sometimes they're not satisfied with the schools. Often it's actually a sick parent on the mainland pulling that family back. So there's a lot of issues. Maybe they don't have the activities that they want. One person didn't come because he couldn't bring his snakes. That's okay.
So the snake factor. Well, setting aside snakes, which I have a feeling we're not going to bend on too much, though I love that, it seems to me like there's certain things that are within our control and certain things that aren't. People are going to continue to have, aging parents in the mainland, and sometimes it's difficult to uproot people and bring them away from their support network. But these things that you're engaged on, loan repayment, certain recruitment, putting people in touch with schools that are, adequate for the families. Are you finding that that's changing the flavor of recruiting? What's working for you?
Well, we work closely with a recruiter group that represents all the medical groups, but it's tricky, to reach out to rural communities. So we're also working with the Hawaii State Rural Health Association, and we actually have a new program where we will pay a community member $100 to pick up a new hire or even a medical student, nursing student at the airport, take them to lunch, show them around the community, get them integrated early, and hopefully have them feel the beauty of the community right away.
Right, and I think that's very, very smart of you, and that's a lot of times it's such a great distance and such a big cultural change. I mean, when I came straight to Ka'u, it was an eye-opener for a young Jewish doctor from Pittsburgh. It was a total change. Now, I was in that part of life where I wasn't yet established, so there was a certain ease of transition that way, but I can only imagine someone coming from the mainland, and though you have that paradise factor, right, in people's minds what Hawaii is, but then reality sets in. You still have to see a lot of patients. You still have challenges with the economics or finding a place to live. If there was a silver bullet, Kelly, what would you say it is? I mean, is it, you've mentioned practice simplification as something. You've been a leader on healthcare loan repayment issues. what is the silver bullet if we're going to get this healthcare shortage problem addressed, or this quote healthcare crisis that the whole country has?
Well, I would love it if we could be the state that doctors wanted to go to.
Yes.
So if we had a payment mechanism that eliminated the hassles of medicine,
Yes.
provided good loan repayment, even we've had talk of physician housing opportunities, tax breaks, but I think if we just had a really nice practice environment for people and they wanted to come here, they got adequate pay, but all the hassle factors were taken care of, and they had a team behind them working with them closely that would do outreach, and it was fun to do medicine. I think it would be great. I think we could do that because we have a small enough number of health insurers that we could all get together and say, we're going to be the happy doctor state.
Yes.
And people are going to want to come here. That is not a silver bullet.
Yes.
I would say that would be a multi-metal bullet, but I think that would be really great.
Yeah, and you're right. We can get most of those people to the table. Over the past many weeks, many, if not all of them, have come and put in their 2 cents. But I like what you're saying, because getting them in the same room and just saying, look, guys, we don't have 30 health insurers to deal with like they might have in California or Chicago. We have very few people that we have to get to agree to a simplified system. We only really have 2 healthcare systems. We've got Hawaii Pacific Health and Queens, and we're seeing them both organize themselves a little bit more proactively. Maybe this is the time where we can sell this idea to recruited physicians that it's easy to plug them into a model where they'll make a good living, will be able to deal with their debt, which is significant. What's the average debt of a medical student coming out of school now?
$150,000, I think.
$50,000. So it's a house for most people, and it's a challenge. As to the challenges with the school system, that's hard, and we try to hope and pray that everyone's going to do their best constantly. But even that, I think, is something that's workable because people can make certain choices. But we are talking about getting young people who are early in their careers.
Right, if we could have special activities for kids interested in health careers, maybe they'd be the doctor's kids, maybe they wouldn't.
Yes.
But we do need a robust pipeline going into health careers,
Got it.
and we're working on that. But I think it would be wonderful if all our insurers could come together with one set of quality metrics, one fairly simple set that could be pulled out of the records by the electronic health records.
Yes.
That would be a huge burden off providers. If they got rid of prior authorizations, or at least for those who don't abuse
Right.
that would be enormous. Rapid time to payment, or like I said, this alternate payment mechanism, I think would be great. And if we could do it as a statewide pilot project and show how attractive it was to providers, I think it would be
I swear.
game-changing.
I swear to God, I made that exact proposal to HMSA. I'm still waiting for an answer. For the 20% of their physicians and healthcare providers that have already proven that they're engaged in healthcare transformation and haven't been utilizing the healthcare system in an appropriate way, to start right there and say, look, zero out the overhead, zero out the administrative hassles, and let us see a lot more patients as providers throughout the day. Work on that shortage. We'll take more individuals with Medicaid and Medicare, but you've got to give a little and help us simplify that way to open up, to find those hours in the day and to find that joy in the practice. So I really like you saying what you just did. Could you touch briefly before we take our next break on telemedicine? How could that fit into this physician shortage and this vision that you have for healthcare?
I think it could be a great boon. We're an island state. It makes sense that we would have a telemedicine infrastructure,
Right.
but we don't.
Yes.
So now that equipment is getting much cheaper, we could create an infrastructure with inexpensive equipment that would allow primary care rural providers to get consults for their patients through specialists off-site.
Right.
I would have even loved it working in downtown Honolulu, getting consults by email even.
Yes.
So it could be a real help for providers. There's lots of issues we face, including malpractice issues, monetary payment issues. There's some legislation going through about that.
Yes.
But basically we need the buy-in and that's from patients and providers. Because right now there's really no pay on the originating end. The specialist can get paid, but not the primary care provider. They're so busy, why should they clear out a room and provide a nurse to do this?
Right.
Except as an altruistic, thing
Yes.
for their patient, which is great.
Right.
But we need to have some business model that can support this in an ongoing way.
And that's where you're talking and have spoken pretty eloquently about having just a different perspective on the whole payment system by putting monies up front and then insisting on a commitment from the provider that they will care for 2,000 people or care for 500 people in their specialty from soup to nuts, and include therefore in their day phone calls and text messages and maybe an hour or two of this telemedicine.
We have specialists who are happy to do their post-op checks by distance.
Yes.
There's no, it's a global fee, so there's no extra money for somebody flying from Hilo to Queens to get a neurosurgery follow-up.
Yes.
We already know the neurosurgeons are backed up
Right.
because we don't have enough. So why couldn't we do it from Big Island by distance?
Yeah, and look, it'll save $200 in flights and a whole day, and sometimes people are hurting. They've had surgery.
Yeah.
So a lot to recommend it. We're going to go to our last break, and then we're going to come back with your vision for healthcare in the future, okay? Sounds
Okay.
good. So I'm Josh Green, here with Healthcare in Hawaii. Thanks for joining us. I'm joined by Dr. Kelly Withy today.
Aloha, I'm Nicole Horry for ThinkTech. For nearly half a century, the Hawaii Foreign Trade Zone No. 9 has brought the benefits of the Foreign Trade Zone program to Hawaii businesses and entrepreneurs. DBET, the Department of Business, Economic Development, and Tourism, operates Hawaii's Foreign Trade Zone program to encourage international business and economic development. The Foreign Trade Zone's mission is to increase the amount of international trading activity in Hawaii, thereby providing employment opportunities for the residents of our island state. For more information, see ftz9.org. I'm Nicole Horry. Mahalo.
Aloha. Welcome back to our final segment on Healthcare in Hawaii. I'm Josh Green, ER Doc from the Big Island. I'm joined today by Dr. Kelly Withy, who's a physician here on Oahu and is the leader of multiple policy programs, including AHEC, the Area Health Education Center, where she's the director. Kelly's given us a wealth of information on anything from healthcare shortage numbers in our state to some of the solutions like loan repayment that we've been implementing, the way she envisions healthcare going forward, on healthcare teams to deal with some of this, and probably a need to expand programs nationwide on primary care for residency programs. But I wanted to turn to Kelly in our last few minutes and say, what's your vision for healthcare in the future? What would you do here in Hawaii to implement some of these ideas? What would be the first kind of big action you would take?
Well, I think we're lucky that we have an assessment of the physician workforce and the nursing workforce through Center for Nursing, but we really don't know how many we need of the other types of health professionals. So I think the first step would be to have a health workforce center where we actually do assessment of all the licensed health professions, and there are even some unlicensed ones that we need to talk about.
Yes.
So we know what we have, and then if we can reach out to industry and have a way to easily survey them about what they see coming up in the next year so that we know what we may be facing soon, then we can work with UH and the other colleges systems here and actually make things that are adaptable to meet the needs. So for example, Kauai needs more ultrasound techs. There is an ultrasound tech training program at Kapiolani Community College,
Yes.
but obviously that's an island removed. So do we make one that's portable and they can go there and train up 20 and then go somewhere else? We could do that. If we knew that need was coming, could we adapt that way? And I think we could if we had it all in one place, so that recruitment to health careers training opportunities, loan repayment, assessment of the specialty, we're all co-located and could work closely together. I think that would be wonderful.
I think that in many ways you've been doing that virtually so far with many of your descriptions of your programs that you're running, but I see what you're saying. To put it all under one roof, to be able to assess the entirety of our healthcare needs and to be able to target solutions. Well, this has been a strength of yours, I think, in many ways, but it sounds like we need a larger commitment to something like that. Anything else you'd like to add to our viewers today about the workforce or the healthcare shortage in our state?
Well, let's see.
What do you encourage moms and dads and people that are thinking about coming to Hawaii?
People who are coming to Hawaii, it's a beautiful place. You can't live anywhere better. So I would definitely give it a try. For patients out there, even the doctors who are patients, just remember to say thank you. Because that's why we went into it, right, was to help people. And it's so heartwarming when someone says, thank you, you've really changed my life, or, you made a difference. I think that's probably the best thing that could happen to a doctor in a day.
And that might be what keeps that doctor staying in practice and
Exactly.
continuing their degree.
Yeah, so don't forget to do that.
Okay.
It's free, it's easy.
Sounds good. Well, we like free and easy for sure. So this has been a really wonderful discussion. I'm Josh Green, Healthcare in Hawaii. I've been joined by Dr. Kelly Withy, who's been explaining what our healthcare shortage challenges are in the state and what many of the solutions will be going forward. Thanks for joining us. We'll be back again next week. Take care.